here, they did it for you, do this. And a lot of it's based on what we did, but it's missing.
1, 2, 3, 4, 5. Is the buzz gone or not?
They don't hear anything.
At least do some of this.
Well, that's probably an impedance that.
So I don't
Yeah, we do, that's all we do is change
Sure, no problem. There's nothing to be done. Yeah, there are things to be done, plenty of things to be done. And they work. I'm not going to stop.
Go to 2. Go to 2.
Identify it quicker, shut it down quicker.
When we were up there, you were working on trying to get some funding for.
Yeah, that's getting close to completion. Right now, we're working on the Holy Grail, which would be, you've seen how we get all the stuff back into the pharmacy, all that liquid, all the injectable stuff. When we test.
What you did is you unplugged this shop.
Expensive test. Well, we've got this. I think you were there when we were just trying this stuff at the time. We brought that in, we're going to get tested more. So, but that's how we're working on it. Sort of, assay to hopefully get done 20% test 100%.
Oh my God.
And then that guy, we had to be part of our patients on sleep, and we would have caught up later that day, not 5 years later. So if we could do that, that would be for patients. But that's somewhere between a dream and a prototype. We got the sensors that work.
You would do it internally.
Yeah, we don't know we're working. But if you have any suggested sources of funding, you can let me know, because I don't know where to begin. We're going to try to commercialize it. And, with that,
Now, do you plug in packages correctly so they can still hear me?
I'll tell you what it is, but we're saying it isn't what you think it is. So if there are 20 things, one of which it should be, it could say it's none of those 20 things. So then you do the spectrophotometer test. This is one, and then you do the gas chromatography spec test. Yeah. So it's just a first really rough cut of the screen. But that's the only thing. It was just the GI endoscopy. Anywhere fentanyl is basically. You got just by definition fentanyl and one. But whenever you have injectables, ICU, our biggest, just sort of really struggling with success is the PCAs, because those are vulnerable to attack.
PCA.
Because the patient can pull down, so there's a bag, and it may get a lot hard. People are smart enough to feed all those things. And so that's where some of it, that's where our greatest area of vulnerability is, because we got to figure out a way to lock it out here. And one of the, did you get that one stuff I sent? So the CDC paper from the United States, the gram-negative bacteremia and saline hospital, that was us going with PCA.
Right.
She thought she was replacing the sterile saline. The sterile saline model, the water was contaminated with on-wall bacteria. So, there are areas of vulnerability that you identify with the
Well, I would think one area of vulnerability is where the nurse or somebody is interacting with the patient.
Because right there at the stop counter.
Right.
We haven't fixed that yet.
That's tough to fix.
Yeah, what I say is the closer, the better you get, the more dangerous it becomes for the patient. Because if somebody can walk into the pharmacy and steal a bottle of pills, no patient.
Right.
The better you get, it drives it right to the stop counter. That's where they do things.
Right. Or switch pills or whatever.
That extra thing, Tylenol, it's a lot of fun.
Yeah.
Just do that all the time.
We were doing good at 2.
Yeah, that's that case.
Like that's good.
Yep,
Yeah.
yep,
Yeah, I don't know if he affected any of the patients or not, but he might have.
put at risk.
Yeah, affected about 50 years. So that's the one testimony.
Oh, is it?
But he was, I had him meet and said, tell me a story. They like stories.
Yeah, they do.
That's perfect to see. But, a local news reporter in the city just did a very nice investigative report on this issue. Took part in, she had just transferred from Boston, where she did the Kwiatkowski case.
Oh, wow.
With Boston, so she arrived. We have a problem here? Yeah.
Well, that case is also and how it just sort of went place to place to place to place.
I mentioned why that happened in my comments, but there was no way that, really. And she just didn't list former employers that had fired her. She just lied. Said, I've never fired any job before. She fired from like 6. You can list those as references. So, when the guy was a pathological liar and drug addict, Epstein, here, he read his testimony in the FBI sound. He sent to the FBI and he was interrogating him and showed his wife and all these people on the signal. It's like, yeah,
Now, the members are coming back today from recess,
okay,
so that's why we're so late in the day. Normally,
Okay.
these hearings are much earlier today. So what you might get, you either get, there are, I don't know, how many members, 8 or 9. My guess is other afternoon hearings I held is that you may be lucky to get half the people.
okay.
If all the people are here, what happens is the chairman starts off with a statement, ranking minority, Ms. Custer starts out with her statement, and then the other folks can make statements as well if they want to, but usually it's then the questions start. They start with the chairman and then the ranking, and then the Republicans go around, and then the Democrats go around to get their 5 minutes of question. They can have 5 minutes to address it. Now, it's usually one round of questions, and then we're done. But if there's only 2 or 3 people here, which I've been in when there's only been 2, they have multiple rounds of questions.
Okay.
So you know what to expect. Next week, next week I have one that starts at 7:30 in the evening. And there's 2 panels. Senator McCain's on the first one by himself, and then VA and GAO are on the second one. So it'll be 8:30 before we get on here. And that's a little more.
I have a really nice office together.
Oh,
He's in the Seattle office, so he doesn't work in DC.
That's awesome.
yeah, I stayed the weekend. I was here last week for something else, and I stayed the weekend because I'll go home tomorrow and then turn around Sunday and come back.
I'm glad I live in the middle of the country for that. My buddy that just started office in Portland, he asked about it, so we're working, 7 and a half days. That's just brutal.
Mic check. 1, 2.
Good afternoon. This hearing will come to order. I want to welcome everyone who has joined us today. Today we will address the lack of oversight and internal controls regarding controlled substances within the Veterans Health Administration that leave facilities open to drug diversion and veteran harm. The diversion of drugs from VA healthcare facilities is an incredible patient safety issue that puts veterans, VA employees, and the public at tremendous risk. Unfortunately, the news has recently been filled with the story after story of drug diversions within VA. In Little Rock, Arkansas, a VA pharmacy technician reportedly used his access to medical supplies websites to order and divert 4,000 oxycodone pills, over 3,000 hydrocodone pills, and more than 14,000 Viagra and Cialis pills at the cost to the VA of more than $70,000. This technician was allegedly selling these drugs on the street where they had a value of more than $160,000. At a VA facility in Florida, a registered nurse was apparently stealing oxycodone and hydromorphone from the hospital to feed her addiction. Keep in mind, these are medications that should have been going to veterans for their care. These issues are in part a result of VA having inadequate procedures in place to safeguard against theft and diversion of controlled substances. A recent Government Accountability Office audit requested by this committee found that one VA medical center missed 43% of the required monthly inspections, mostly in critical care areas such as the operating room and the intensive care unit. In addition, 3 other facilities did not follow all of VHA's requirements for inspections of controlled substances. This is not the first instance where weaknesses were identified in VA's controlled substance inspection program. In 2009 and 2014, the VA Office of Inspector General found that some medical facilities were not conducting monthly inspections and some inspections were incomplete. VA has been given multiple opportunities to address these concerns. This leaves me wondering what VA is doing to repair the lax oversight and apparent absence of accountability regarding these issues within VHA. To make matters worse, there are also issues with drug testing employees to ensure that they are suitable to provide care to our veterans. A 2015 Office of Inspector General report found that VA medical centers were not conducting pre-employment and random drug tests for testing designated positions in many instances across VHA, which amounted to tens of thousands of employees not receiving drug tests required by the Drug-Free Workplace Program. Most recently, in January 2017, the OIG found high backlogs in background checks to include drug testing for high-risk positions at the Atlanta VA Medical Center. It is precisely these tools that have been put into place to help protect patients and healthcare organizations from drug diversions and harm. However, VA does not seem to be taking them seriously as it should. Based on the oversight reports and numerous diversion incidents we will discuss today, I'm concerned that VA's Controlled Substance Oversight Program is not working and that staff who fail to follow proper procedures are not being held accountable for violations. In case after case, what we see are examples of drugs being diverted for personal use or personal gain, yet there does not seem to be much progress made by the VA to correct the glaring problems that allow it to happen. What is even more concerning is that the programs to help deter diversion or identify illegal employee drug use are not being implemented consistently within the VA health system. We are in the midst of an opioid epidemic, and it's time for VA to start making effective changes to avoid putting veterans and the employees who serve them at risk. With that, I recognize Ranking Member Custer for her opening statement.
Thank you, Mr. Chairman, and thank you for choosing this topic. I'm particularly interested as the co-chair, the founding co-chair of our Congressional Task Force to combat the heroin epidemic, and I appreciate this testimony. This afternoon, we are again examining VA's role in ensuring that prescription drugs are safely controlled in VA medical facilities. Less than a year ago, former Chairman Kaufman and I held a hearing of the O&I subcommittee on this very issue in Colorado because the Drug Enforcement Agency, DEA, found several violations in the Denver VAMC. We continue to hear disturbing reports in hospitals and clinics in our communities that some healthcare employees are stealing controlled substances for their own personal use or personal gain. We know that these cases are on the rise throughout the country. One healthcare employee diverting controlled substances can be a serious public health risk and can cause significant harm to many patients. We learned this lesson the hard way in New Hampshire with a technician who was injecting himself with fentanyl at a hospital in Exeter, New Hampshire. But it turned out this had started at the Baltimore VA Medical Center and continued in more than a dozen hospitals in other states, infecting up to 50 patients in our community with hepatitis C, and some of these patients were veterans. From this example, it is clear that the nationwide trend of opiate diversion also impacts our VA. The VA health system is one of the nation's leading prescribers of opioid medication. Diversion in the VA threatens the safety of veterans and hampers efforts to address the opioid epidemic in our communities. Preventing diversion of these substances should be a paramount concern. That's why I find the GAO and IG's findings particularly troublesome. It's unacceptable that some VA medical facilities are not conducting routine inspections to prevent and identify drug diversion. Background investigations that could potentially identify finding employees who have diverted drugs or who may have a drug substance use problem were backlogged in Atlanta. Healthcare employees at the Atlanta Medical Center were not subject to drug testing for 6 months, which could identify diversion of prescription drugs. We need to get to the bottom of why these safeguards and processes are not being followed. I want to know if the procedures, when followed, would work to prevent drug diversion, and I want to know if VA has the resources it needs to conduct the inspections, the background checks, and to administer its drug-free workplace program. I'm also concerned about the VA hiring freeze that's currently in place, and that VA HR employees are not exempt. The GAO and IG identified that staff need more personnel and more training to properly conduct these inspections. They also identified the need for more HR personnel to address the background check backlog in Atlanta. Without adequate support staff in place, VA medical facilities will continue to struggle to comply with the procedures and programs that they must follow to ensure that our veterans receive safe care. Finally, I look forward to learning about progress at the VA with regard to the opioid safety initiative that we passed within CARA, the Comprehensive Addiction and Recovery Program, just last year to bring down the rate of opioid prescriptions for all of our veterans. We must do everything we can to help veterans suffering from chronic pain and to help veterans struggling with substance abuse and addiction. The opioid epidemic is destroying the lives of veterans and their families in communities across New Hampshire and all across the country, and we need to work together to find innovative solutions to end this epidemic. As I say to my colleagues, the heroin does not choose R's and D's. We can work together, and we are proud champions of the Comprehensive Addiction and Recovery Act that we passed last Congress, and I look forward to hearing about VA compliance. Thank you, Chairman Bergman, and I yield back.
Thank you. Thank you, Ranking Member Custer. I ask that all members waive their opening remarks as per this committee's custom. With that, I welcome our first and only panel who is now seated at the witness table. On the panel, we have Dr. Carolyn Clancy, Deputy Undersecretary for Health for Organizational Excellence. She is accompanied by Dr. Michael Valentino, Chief Consultant for the Pharmacy Benefits Management Services of the Veterans Health Administration. We also have Mr. Nick Dahl, Deputy Assistant Inspector General for Audits and Evaluations. He is accompanied by Ms. Amy Volcanos, Health System Specialist for the Office of Healthcare Inspections in the Office of the Inspector General. Finally, we have Mr. Randall Williamson, the Director of the Healthcare Team for the Government Accountability Office, and Dr. Keith Berg, Consultant in Anesthesiology and Chairman of the Mayo Clinic Enterprise-Wide Medication Diversion Prevention Committee. I ask that the witnesses please stand and raise your right hand. Do you solemnly swear, under penalty of perjury, that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Please be seated. Let the record reflect that all witnesses have answered in the affirmative. Dr. Clancy, you are now recognized for 5 minutes.
Good afternoon, Chairman Bergman, Ranking Member Custer, and members of the subcommittee. Thank you for the opportunity to discuss oversight of controlled substances and drug-free workplace program at VA facilities. I will address inspections to minimize diversion, drug testing for selected employees, and our commitment to accountability for employees who do not live up to our core values. I'm accompanied today, as you mentioned, by Mike Valentino from Pharmacy Benefits. GAO's recently released report on medical facility controlled substance inspection programs in 4 of our facilities has prompted a swift response. We concurred with GAO's 6 recommendations and are now implementing them, expect them to be fully implemented by October of this year. We conducted a conference call last week with over 450 field-based staff to launch the action plans and to provide tools that support that effort, followed by distribution of written instructions. Additional dissemination efforts are planned over the next 2 weeks. Although GAO and VA Inspector General identified selected instances of noncompliance with these robust controls, I believe the system is working as designed to make it difficult for VA staff to divert drugs, and most importantly, to give us the tools to be able to detect diversion rapidly and take action when it does occur. VHA implemented robust controlled substance internal controls in the early 1980s. In many cases, these measures exceed those required by the Controlled Substances Act, and we believe they align closely with Mayo Clinic's recommended best practices. Data from January 2nd of 2014 through March 11th of 2016 show that VA's reported controlled substances loss rate is 0.008%, or 8 per 100,000, and it is VA's very own internal controls that lead to the vast majority of diversion cases being identified. The use of illegal drugs by VA employees is inconsistent with the special trust placed in those who care for veterans. The Inspector General recently reviewed allegations at the Atlanta VA Medical Center of a backlog of unadjudicated background investigations and found that mandatory drug testing of new hires did not occur over a 6-month period, resulting in a backlog of about 200 background investigations. It was also found that the drug-free workplace program was not administered from November of 2014 to May of 2015. Atlanta VA leadership implemented a number of changes in 2016 in response to these recommendations, such as moving the Human Resources Department under the direct supervision of the Medical Center Director and developing a secondary database for staffing and tracking all background investigations. We expect that that backlog will be cleared by the end of this March, and if not, we'll keep you informed. In addition, VA has made great strides towards improving the drug-free workplace program. In October 2015, drug program coordinators began certifying on a monthly basis that employees selected for random drug testing were tested, when they were tested, or why they were not tested. The VA is also developing procedures to ensure the drug testing coding of employees in approximately 180,000 testing designated positions is accurate and complete. On March 1st of 2016, the Assistant Secretary for Human Resources and Administration published a memorandum stating that 100% of all applicants tentatively selected for appointment to a testing designated position be drug tested prior to appointment. VA works closely with local, state, and federal law enforcement entities to identify specific geographic areas with reported mail losses, and VA's identification of loss clusters has led to successful arrests, prosecutions, and convictions. VA has developed a culture of controlled substance loss reporting and has adopted a practice of over rather than under-reporting suspected cases of diversion. Mr. Chairman, I'm proud of the health care our facilities provide to our veterans, including prescription drug services. The issues we're discussing here today are closely related to our nation's overarching struggle with opioid use. As a whole, our nation needs to come up with a better alternative to pain management than opioids. VA is at the forefront of this challenge with our opioid safety initiative, which we pioneered in August of 2013. We're actively reducing the number of opioids we prescribe and the number of veterans receiving these prescriptions. Instead, we're offering a variety of complementary and integrative medicine treatments for chronic pain, such as chiropractic and acupuncture, among many other options. Initiatives like these will reduce the number of controlled substances VA prescribes, making it easier to maintain their oversight. With support from Congress, we look forward to continuing to improve our oversight of controlled substances and drug-free workplace programs, which will further improve the care of our veterans and the care that they deserve. Thank you for the opportunity to testify, and I look forward to your questions.
Thank you, Dr. Clancy. Mr. Dahl, you are now recognized for 5 minutes.
Mr. Chairman, Ranking Member Custer, and members of the subcommittee, thank you for the opportunity to testify today on the Office of Inspector General's work related to drug-free workplace programs and the oversight of controlled substances at VA facilities. I am accompanied by Emerfia Valkanos, who is a member of the OIG's Healthcare Inspection Staff in Manchester, New Hampshire, and is also a former VA pharmacist. The Federal Drug-Free Workplace Program was initiated with the goal of establishing a drug-free federal workplace. The program made it a condition of employment for all federal employees to refrain from using illegal drugs on or off duty. VA has designated safety-sensitive occupational series as testing-designated positions, including positions such as physicians, nurses, police officers, and motor vehicle operators. In recent years, the OIG has completed 2 projects that assessed aspects of the drug-free workplace program. In March 2015, the OIG issued a report detailing the results of an audit of VA's program. We identified program weaknesses in 3 areas. First, pre-employment applicant drug testing. If a tested applicant has a verified positive test result, VA should decline extending a final offer of employment. However, we reported that VA did not ensure compliance with policy to drug test all applicants selected for a testing designated position prior to appointment. Instead, VA selected only about 3 of every 10 applicants for testing. Second, employee random drug testing. We estimated VA achieved a national drug testing rate of 68% of employees selected for random drug testing in fiscal year 2013. In our review of 22 randomly selected facilities, we found 4 facilities did not test any randomly selected employees, 10 had compliance rates ranging from 31 to 89%, while the remaining 8 facilities tested at least 90% of their randomly selected employees. We also estimated at least 9% of about 206,000 employees in testing designated positions were not subject to the possibility of random drug testing because they were not properly coded with the drug test code in VA's personnel system. Those not subjected to random drug testing included physicians, nurses, and addiction therapists. Finally, reasonable suspicion drug testing. We reported VA lacked sufficient oversight practices to monitor whether facilities referred all employees with a positive drug test result to the Employee Assistance Program. Based on our work, we determined VA's program was not accomplishing its primary goal of ensuring illegal drug use was eliminated and VA's workplace was safe. We made 5 recommendations, and as of today, 1 recommendation remains open. A more recent report focused on human resources issues at the Atlanta VA Medical Center. During this review, we substantiated an allegation that there was no drug testing of employees in testing designated positions for at least 6 months in 2014 and 2015. Despite the lack of drug testing for 6 months, we found no indications VA management at either the local or the national level was aware of the lapse. Because no drug testing occurred, the Atlanta VA Medical Center lacked assurance that employees who should have been subject to drug testing during this period remained suitable for employment. We made 2 recommendations focused on the drug-free workplace program, and VA reported they have taken action on these recommendations. VA also requires that managers at VHA facilities ensure that a controlled substances inspection program is implemented and maintained. The OIG has reviewed VA's management of controlled substances during our combined assessment program reviews. We rolled up the results of our work in June 2014, and GAO references that work in their recent report. The OIG also has a vigorous investigative program related to drug diversion. We primarily focus on 3 categories. First, the diversion of controlled and non-controlled substances by VHA employees. The diversion of drugs by healthcare providers for personal use is a serious issue that the OIG diligently pursues. Next, the diversion of controlled and non-controlled substances for illegal distribution, which involve cases where VA pharmaceuticals are diverted or stolen for the purpose of illegal sale. Also, the diversion of controlled substances via theft of mailed pharmaceuticals. Our investigations have revealed mailed pharmaceuticals are vulnerable to theft at any point in the process, with the most common occurrence being theft by employees of the mail carrier. In conclusion, the OIG has provided cross-cutting oversight of the drug-free workplace program and controlled substances inspections through our audits and inspections. This oversight is necessary to ensure VA takes the steps necessary to reduce risks to the safety and well-being of veterans and VA employees by having and following proper program controls. We also actively investigate drug diversion and seek prosecution for those engaged in drug diversion. Based on our work in recent years, we have concluded VA lacked reasonable assurance that it is achieving a drug-free workplace and adequately securing controlled substances. Mr. Chairman, this concludes my statement. We would be happy to answer any questions that you or other subcommittee members may have.
Thank you, Mr. Dahl. Mr. Williamson, you are now recognized for 5 minutes.
Thank you, Chairman Bergman and Ranking Member Custer and members of the subcommittee. The increase in the prescribing and use of opioids over the last 2 decades, sometimes referred to as the opioid explosion, has brought with it the need for medical facilities to undertake efforts to prevent diversion of opioids and other controlled substances by facility employees for their own personal use. Diversion of controlled substances can compromise patient treatment, can be costly to the facility, and can cause harm in our communities for those that are the recipients of illegally obtained controlled substances. I am here today to discuss our recent report on VHA's efforts to prevent diversion of opioids and other controlled substances through its controlled substance inspection programs. All VA medical facilities that store and dispense controlled substances are required to undertake monthly inspections of all areas within the facilities that are authorized to have controlled substances. Each facility director is responsible for overseeing the inspection program and appointing a coordinator to manage the inspectors who conduct the inspections. Usually, both the coordinators and the inspectors have other responsibilities within each facility and work part-time on the inspection program. The coordinator is responsible for ensuring that monthly inspections are conducted and for submitting reports to the facility director summarizing inspections and any trends. We found that the program was not being managed according to VHA policy and needed improvement in certain areas. First, monthly inspections are not always being conducted as required. We visited 4 VA medical facilities across the country and found that over a 14-month period, one facility missed 43% of the required inspections, while another missed 17%. The operating rooms in one facility, for example, were not inspected at all because we were told that the inspectors needed to arrive before or after normal operating room hours and could not do so because of their conflicting work schedules. Second, when conducting the inspections, facility inspectors did not always follow VHA policy requirements, as was the case for 3 of the 4 facilities we visited. For example, Inspectors did not always verify that controlled substances had been properly transferred from pharmacies to automated dispensing machines in patient care areas. Or inspectors didn't always count all of the controlled substances stored in patient care areas. Third, we found that local written inspection procedures were not fully consistent with VHA policy requirements. We found this problem at 3 of the 4 hospitals we visited. These 3 weaknesses increase the risk of diversion at VA facilities. We found that many of these problems were allowed to happen in part due to poor oversight at the facility and network levels. Facility directors at 2 of the 4 facilities we visited did not consistently perform their oversight responsibilities for the inspection program, which include reviewing monthly inspection reports and implementing corrective actions if missed inspections or other problems are identified. Also, we found that 2 of the 4 network managers who had oversight responsibilities for the medical centers we visited did not review facilities' quarterly trend reports as required. The Controlled Substance Inspection Coordinator is required to prepare and submit these quarterly reports based on trends identified in the monthly inspections. Further, one of the 2 networks that actually did review the quarterly trend reports took no action to ensure that one of the facilities in our review that had not prepared quarterly trend reports had a corrective action plan to do so in the future. Aside from the oversight weaknesses, we found that there is limited training for coordinators to better ensure that they have a complete and detailed understanding of VHA's inspection procedures. Finally, 2 of the facilities we visited had backup coordinators to help manage the inspection process and complete inspections when the primary coordinator or inspectors could not carry out their responsibilities because of pressing job duties or unforeseen circumstances. We recommended that VA adopt this type of practice system-wide, and VA concurred. VA also concurred with our 5 other recommendations to improve the process and provide better oversight. This concludes my opening remarks.
Thank you, Mr. Williamson. Dr. Berg, you are now recognized for 5 minutes.
Chairman Bergman, Ranking Member Custer, and members of the subcommittee, thank you for the opportunity to speak with you today about drug diversion from the healthcare workplace. Such diversion is a crime that endangers all patients, healthcare employers, coworkers, and even endangers the diverters themselves. While we have long known of these hazards of patients being deprived of pain medication by diversion, only fairly recently has the grave risk to extremely vulnerable patients been revealed by outbreaks of disease, such as blood poisoning by bacteria or viruses that have been transmitted by drug diverters swapping syringes in the commission of their crimes. In the process, many patients have been infected with potentially fatal illnesses. I have attached for your review a paper authored by the CDC investigators outlining 6 such outbreaks over a 10-year period that resulted in illness and death in patients. One of these diversion infection scenarios included Veterans Affairs patients being exposed to a diverter that communicated his hepatitis C infection to approximately 50 patients. This individual was referred to earlier in the introduction comments. This diverter was a radiation technologist who traveled the country working for multiple employment agencies. He had been fired from multiple jobs for diverting fentanyl for his own use. But by simply lying about previous terminations on job applications and in the absence of a national registry of radiation technologists, he had no trouble finding employment. In the darkened invasive radiology suites, he would swap fentanyl syringes on the anesthesia cart with ones he had previously used to inject himself. He would then excuse himself to a restroom, inject himself with the stolen fentanyl, draw up tap water, and repeat the process with the next patient's fentanyl. In this manner, he conveyed his potentially lethal illness to many innocent victims. The patients described in these 8 outbreaks were all extremely vulnerable positions, either undergoing an invasive procedure while under anesthesia or while in an intensive care unit. Clearly, such behavior is unacceptable, and the recognition of these dangers posed by diversion, the Drug Enforcement Administration requires stringent drug control policies and procedures to be put in place to protect controlled substances from attack across all points of the manufacturing, distribution, dispensing, administration, and disposal spectrum. The drugs used in the healthcare setting are highly sought after drugs of abuse, both by addicts and by those who would profit richly from the sale of stolen drugs. Experience at the Mayo Clinic and elsewhere has shown the necessity of having robust surveillance, detection, investigation, and intervention programs in place in order to minimize the risk to all involved. While it will be impossible to completely eliminate drug diversion from the healthcare workplace, it is imperative that robust systems rapidly detect and halt such activity. I have attached for your review an article from the Mayo Clinic authors, myself included, which outlines our program from its inception to its very successful implementation. While we continue to try to improve our system, it has proven quite effective in identifying a host of drug diverters since implementation 7 years ago. Diverters come from diverse backgrounds and include physicians, pharmacists, pharmacy techs, nurses, nursing students, nursing assistants, janitors, patients, patient family members, nursing home attendants, hospice workers, and strangers off the street. These stories are incredible, but they all point to the powerful draw that these drugs have over addicts. As such, it is not good enough to merely have effective policies and procedures on the books. They must actually be rigorously followed. Diverters are generally clever and desperate, and they will gravitate into areas of a system where they perceive the drugs to be most vulnerable to attack. It therefore behooves any healthcare facility to have a reputation for being effective at rapidly identifying, terminating, and prosecuting drug diversion and drug diverters. Only by doing so can we protect the most vulnerable of our patients from preventable harm. As I've stated, this problem will never go away, so we must become very good at rapid intervention. Only by instituting and following effective anti-diversion policies and procedures will this be possible. I thank the committee for its attention to this very important issue and stand ready to answer any questions you may have. Thank you.
Thank you, Dr. Berg. The written statements of those who have just provided oral testimony will be entered into the hearing record. We will now proceed to questioning. Dr. Clancy, in your testimony, you state that the VA performs an actual count of all controlled substances every 72 hours. Who performs these counts, and who oversees that these counts actually occur at each facility?
So what I saw when I made a more or less unannounced visit to the DCVA last week is that pharmacy techs who are working in the vault are doing that, and they are double counting as they're doing it. So in other words, there are 2 assistants who are each verifying, because counting a lot of pills is prone to missing one, and so forth. And that is further verified by a supervisor.
Given the weaknesses identified by the OIG and more recently by GAO, how can VA Central Office be sure that these counts are taking place and that they are accurate? You observed one.
Yes. Well, I think that Dr. Berg just said it well. We have very good policies in place, but it's very important that they're rigorously followed. So we are exploring right now how we might do some backup audit to make sure that those policies are followed. As I mentioned in my opening, we actually have already disseminated written statements to the field. Would be happy to make a copy of that memo available for the record or just for your interest. But again, it's very, very important to know that this actually happens, that our aspirations are as good as what we're delivering on.
Thank you. Dr. Clancy, how many cases of drug diversion has the Controlled Substance Inspection Program identified in the last 2 years?
So what I have here is a poster, which we could make available to the committee. Mike, if you could just turn that around, of controlled substance losses by type. So the data that we looked at specifically goes from January 2nd of 2014 to March 11th, I believe, of 2016. What you see is that 91.4% of these losses occur outside our facility in the mail system. And that leaves about 1.5%, I believe, from employees internally. But again, this is something that we're checking all the time. And if there's any question whatsoever, VA police are engaged as well as the Inspector General's office, and they've been most helpful.
And of those losses that occurred at VA facilities outside of the loss in the postal, will you be able to provide the subcommittee a list of those facilities where the drugs have been reported missing or stolen in the last 2 years?
We would be happy to do that.
Okay. Mr. Williamson, what is the role of the medical center directors in terms of ensuring inspections and proper oversight?
Well, they are the key at the facility level to looking at the monthly inspection reports, picking off any issues that come to pass there, from misinspections, inspections that are not done correctly, things that the coordinator report to them, and they then are responsible for holding somebody accountable for correcting that.
I see I've got about a minute left here. Dr. Berg, VA's Office of Human Resources Management reported to the OIG that they interpreted language in the VA's drug-free workplace handbook to require only some job finalists for testing designated positions to be drug tested before being appointed. Would this be an acceptable practice in your healthcare organization?
I believe in our healthcare organization, we do post-offer of employment testing on all applicants.
And what are the consequences for hiring healthcare workers prior to drug testing or completing background checks?
Well, you might be letting the fox in the henhouse. You might be letting somebody who would test positive and is in fact an addict into an area where they can get their hands on drugs. There's an example of that in the Denver area within about 3 years ago. Kristen Parker, she's now spending 30 years in federal prison for infecting about 36 patients with her hepatitis C. But in retrospect, she was a heroin addict that took a job in a facility and started diverting fentanyl.
Thank you. Ranking Member Custer, you are recognized for 5 minutes.
Thank you, Mr. Chair, and thank you to our panel, and I particularly want to thank the GAO and the IG for their helpful reports. I want to focus in on evidence demonstrating we know what a successful drug diversion deterrence program would look like, and yet we continue to have this problem at various VISNs. And my question is, currently the VA gives authority to the individual facilities to implement these inspection procedures. But is there any reason, and I guess this is for Dr. Clancy, why the VA could not streamline this process and apply one standard to all facilities and in fact have an inspection team based out of the central office that would go out to the VISNs? It seems what I'm hearing is that this is often just an added task. In fact, in one case, it was somebody was a food services worker this was just an add-on. It doesn't seem as though we're taking it sufficiently seriously. And wouldn't it make more sense if we had an office of inspection that would then go out to the VISNs, perhaps, you know, as you did yourself, without advance warning, and do these checks?
Well, thank you, Congresswoman. That's exactly what we're going to be looking into, and I think what we need to look at is how much of this could be done remotely, how much of it requires on-site presence, and frankly, how much can we identify ahead of time which facilities are likely to have the most challenges. I suspect that in some instances, but we need to test this, we will know which facilities are more likely to be compliant. I guessed correctly which one was the facility in the GAO report based on many, many other things I knew about that particular facility, and I wasn't incredibly surprised by the distribution of the others, but we need to actually up our game and make sure that great policies are implemented consistently. There's no question about that.
And at least have consistency. What I'm curious about is having a system that would be consistent throughout. So I have a couple of minutes. I want to return to the issue of reducing the amount of opiate medication generally in the VA population. We had testimony from a medical researcher that out of the 60,000 surgeries a year, 99% of people get opiate medication, and 1 in 15 will become a chronic user of opiates. And that's what's feeding this epidemic. Can you talk to me more about both the program within CARA, encouraging VAs to reduce the use of opiate medication, or any other examples that you might have in the system?
Of course, and thank you for the question. I'm happy to report that we are on track for all the provisions in CARA. Incredibly enough, VA's portion of that is named for a veteran who died under our care, and I was literally speaking with his father yesterday, and I've been most impressed by the family honoring the experience of their son by working with us to make sure that we provide better care. VA has really been on the forefront of reducing the use of opioids. So beginning in August of 2013, we've seen a 31% reduction in the number of patients receiving opioids. We've seen a 56% reduction in the number of veterans who are receiving an opioid and another type of drug has a particularly high risk for adverse reactions. We are doing much more frequent urine testing because we're trying to minimize diversion from patients, veterans actually selling the drugs that they got at VA to elsewhere. So the right answer on a urine drug screen is positive, that you're actually taking the medications you received. We're seeing the overall dosage of opioids has decreased quite significantly and we have seen these results at a time when we've seen an overall growth in the number of veterans we are serving. I want to be clear, we're not done, and we will continue to monitor this. And I'm very proud of the work that we are doing to offer veterans alternatives to chronic pain management.
So my time is up, but I would just say to the chair that as we continue, I'd love to have further testimony about the chronic pain programs and how we can bring down the use of opiate medication. Thank you.
Mr. Boss, you are recognized for 5 minutes.
Thank you, Mr. Chairman. And Dr. Clancy, I'd like to continue down that same, the ranking member actually asked the first part of the question I was going to ask, but I still want to go down that, and that was, okay, the reports from 2009 and then again in 2014 on the weakness that the VA Controlled Substance Program had. Now, you kind of explained what the VA Central Office was doing, but what about the VISN and the faculty level? What are we doing there?
So every one of our networks, that's a Veterans Integrated Service Network, has a pharmacy lead there. I will say that it's my understanding that there's some variability in terms of how many other members of the team that they have. Many of them are quite strong in terms of reviewing facility reports and providing that kind of oversight. Others, it's my understanding, are less so. I'd be happy to provide more detail for the record. But I think that we need a very consistent approach. Here's the facility's responsibility. Here is the second line, which should be the network, and then central office providing what is sometimes referred to as the third line of defense. I'm quoting from sort of accepted practices in internal audit, which is an area that we have just started up within my group.
Okay, I know that you've been trying to do that since the 2014 report, but why do you suppose that when all of a sudden the GAO came back, many of those same weaknesses showed up again? What are we not doing correctly to move quick enough to try to deal with this? And it is getting to a point of, and not just in the VA, it's nationwide, the epidemic that we're dealing with, but we have to set the example.
I would agree, and that's precisely how we think of it, as setting an example. I think to some extent, I believe it was Mr. Williamson referred to the fact that some of these coordinators have collateral duties. I do note that for many of our facilities, anesthesia and the operating rooms tend to be areas probably because of the hours where there have been problems conducting inspections. Every facility has been in our system has been redirected quite recently to have a backup coordinator. My colleague from pharmacy, who's here today, not Mr. Valentino, one of his top lieutenants, came with me the other day, and he noticed that maybe there was a little problem with not randomly conducting the inspections throughout the month. If you let it go till the end of the month, which is understandable, but nonetheless, if stuff happens that week, that means you will have slipped a month and so forth. So that is the kind of thing that I think we can and will improve on.
Okay. My next question is for Mr. Dahl. In your investigation related to the 2015 and 2017 reports, how many positions identified as no background check completed were the high risk or the testing designated positions? Do you know that?
Well, the 2015 report did not get into the background investigations. Our 2017 report, which was focused only on the Atlanta VA Medical Center, I wouldn't have that information at hand, but I'd be happy to look into that.
We could get a copy of that to try to figure that out, because we want everyone tested, because as you described, and somebody at the panel did, that everyone is at risk with this, anyone we hire. That being said, if we're going to drop them into those high risk positions, we've definitely got to do some backing up and making sure. And I'm kind of short on time here, but Dr. Burge, and this is a question that I'm sure my constituents and people throughout this nation are going to ask: would your healthcare organizations hire a clinic professional prior to completing a background check?
No.
That's what I thought. Okay, what risks are associated with hiring a clinical staff prior to a background check?
Well, one source of frustration is like when we are interviewing an applicant for, say, our nurse anesthesia school, that employment law forbids us to ask, have you been through treatment for chemical dependency before? Well, we have had such people come in that develop fentanyl addiction, and then in retrospect, well, they've gone through treatment for cocaine abuse in the past. So in some ways, we're barred from asking some of those questions, but we would complete the post-offer of employment drug testing.
And if I can just add to this, first off, let me say this, and I know I'm running short on time, Mr. Chairman, but this is an issue I've dealt with on the state level and then here at this level as well. The one thing we want to remember is how vitally important those tests are, because this disease, and it is a disease, to be an addict. I had a friend that one time when we begged him to talk to us, he gave us an information, it wasn't correct, and he came back and said to us, what part of I'm an addict, I lie, don't you understand? That's why it's so vitally important to not only do the question, but make sure that we do the follow-up checks. And the concerns I see is the holes that are existing in the system. We can't have it. We want to do everything we can to empower you to try to stop this epidemic that is affecting, and it doesn't matter whether what your race is, what your gender is, what your socioeconomic status is. We've got to continue to work on this. So thank you very much, Mr. Chairman. I yield back.
Thank you. Mr. Walsh, you're recognized for 5 minutes.
Thank you, Chairman, and thank you all for being here. Dr. Clancy, you and I have a long history in this, too. Just for the committee's sake, for the new members, the first piece of legislation that we authored in 2008 was the pain directive that went to the VA to set up the STEP pain management. That was with a lot of work that came in from the folks from the Mayo Clinic, from Boston Scientific, and all of the best practices working in conjunction with the VA. This is one of those issues that the seamlessness between the private sector and the VA is pretty strong. We all have the same issues. But my colleagues were getting at it, and the ranking member knows this. The fundamental issue here is pain management. It's in the beginning, and our nation goes through these cyclical issues of issuing opioids, pulling them back, which creates its own problem. The diligence on the control side, we can always do better on that. And I think there's been some great suggestions there. But I would suggest to all of us, that program, am I right, Dr. Clancy, was never fully implemented. We had this discussion out in Tomah, Wisconsin here about 18 months ago. Did we ever fully implement it before it expired?
I'm not sure, but I could get back to you on that. What I do know is, thanks to the new legislation that Representative Custer was asking about, the CARA bill, we are now making sure that there is pain management expertise and teams accessible by all our facilities. For some of our facilities, that's going to be partly virtual, but as an integrated system, we can do that.
But it builds on that same principle and
Absolutely.
fully implemented the same thing that's happening in the private sector, because most of us know as the VA goes, so goes the rest of the system in a lot of ways, just because of the sheer volume of this. How much collaboration, Dr. Clancy, do you have with, like Dr. Berg, experts that are out there?
Well, I am just meeting Dr. Berg today, although we have a mutual colleague friend. But we consult with others pretty broadly. And in fact, when the CDC published their guidelines on opioids last year, they drew on expertise from a number of folks in the VA, including from your district. But
Yes.
because, as you said, this is all about a common health challenge shared by the country.
Dr. Berg, again, thank you for being here, and you and your colleagues over the years have, I think the thing about this is to not think everything is reactive, and this recent opioid epidemic and the overdoses and everything else that come with it, that was not a surprise to many folks like yourself. But when you said Mayo Clinic saw that you had maybe some holes in there, you decided to turn around and now recognized as one of the best. How long did it take you to implement that before you saw or expected to see change?
We were probably about a year and a half in creating our system, and that was in response to a tampering diversion that ended up on the front page of the newspaper and embarrassed us. We tried to work through every spot in the supply chain where we were vulnerable and figure out a plan to address that. And it takes some time to go through that process.
And you have facilities, how many facilities?
Well, we have the Midwest, the Minnesota facility and a surrounding area. We also have Jacksonville, Florida, and some small surrounding area in Scottsdale, Arizona, and some surrounding area.
So the numbers, you have 50,000 plus employees roughly.
About 70,000 employees.
About 70,000 for the entire system on that. So this is a big healthcare system that's able to, I think one of the maybe frustrations, and I know it frustrates you too, Dr. Clancy, is sometimes the slowness of the reacting to these situations as the bureaucracy takes time. You're feeling comfortable now, Dr. Clancy, that there is, with the new legislation, with the emphasis on this, with the situations that come up that are unacceptable, and the thing is I think for many of us, we know that what's happened and these situations that have been brought to light are happening in the private sector. Our responsibility is the VA. Our responsibility and our, both from an oversight and a legal responsibility, but also from an ethical responsibility, is to those veterans. Do you feel like it's moving quickly enough for you?
I'm excited by how enthusiastic our employees are about this. I mean, this is a national problem. I'm excited by the progress we've made, but we will be tracking this very, very closely.
Because I get it too. They're embarrassed by this. We recognize that when it's not done right, the issue in Toma and the surrounding areas impacted. This is a tragic situation. I guess the news for all of us in here is we can do something about it and do something quickly because we have that ability in the VA. And I guess I'm just looking to see these things maybe be implemented as quickly as we can. And I know you are too. And I thank you all for your testimony.
Thank you.
Thank you. Mr. Poliquin, you're recognized for 5 minutes.
Thank you, Mr. Chairman, very much. Mr. Dahl, you're with the Inspector General's office, correct, sir?
Yes, sir.
Yeah, Mr. Williamson, you're with the Government Accountability Office?
Correct.
Okay, great. You two gentlemen, please, the last 8 years or so, you've repeatedly reported that there's a problem with keeping track of the drugs at the VA facilities, making sure they're not stolen and sold and so forth and so on. Is that correct? Okay, so would you both conclude that we still have a problem?
I'm sorry, I missed that.
Would you conclude that we still have a problem?
I would think that based on GAO's recent work, that there is still an issue.
Thank you. Dr. Clancy, you're the Deputy Undersecretary for Health for Organizational Excellence. What does that mean? Does that mean in part keeping track of who's got these harmful drugs and make sure they're not put in the wrong hands?
What it means is providing oversight for quality, for safety of care, and for integrity.
Okay.
And integrity is about compliance with our stated policy.
What person at the VA Dr. Clancy, what one person is responsible for this problem? Who's the head banana?
That would be the Undersecretary for Health.
Who's that?
Right now, that is someone in an acting position. Dr. Poonam Aleg, you know that our Undersecretary was recently confirmed as Secretary.
Could you spell that name for me, please?
Alaigh.
Okay. And you report to that person, that individual? You report to that individual,
Yes.
is that correct? Okay. When someone is caught, Dr. Clancy, stealing drugs and selling them or making them available to folks that shouldn't have them, like our veterans that were working so hard to help, what action is taken?
It depends on the specifics of the circumstances.
You call the cops?
Yes.
You do? Good.
Yes.
Okay. And what sort of actions recently have taken place in the system that you can share with us about people being held responsible for this abuse?
I think you have probably seen from newspaper articles that a fair number of people that we have brought to the attention of law enforcement have in fact been convicted and are serving time. They're paying their debt to society, and we would be happy to get you a whole list for the record.
That'd be great. Kate, we'll make sure we get that list. Thank you very much. Integrated Services Networks, who are they, what do they do, and how are they involved in this?
So we have facilities, that is hospitals, clinics, and so forth, all over the country, including Alaska and Hawaii and Guam and even a clinic in Manila and so forth. So big span of reach. And so the system is organized into these networks. This is sort of a sub-management.
Okay, and what does the Integrated Service Networks do?
They manage and provide oversight for the facilities and clinics.
Okay,
in
so
that
they'd be
particular
responsible
area.
also for making sure that we have a good head count, so to speak, on where the drugs are and where they're being dispersed, correct?
Yes.
Okay, good. And who's the head person over there?
There are 18 of these networks, so in your area, that would be Dr. Michael Mayo Smith for
Okay.
New England.
We'll make sure, Kate, we get a list of these people also. Mr. Williamson, have you found in traveling around the country and dealing with separate VA facilities that there is inconsistency? And I think Congresswoman Custer asked this question earlier. I want to make sure I get it straight. There's inconsistency in which organizations, which medical facilities actually do a better job than not in following these protocols?
Absolutely.
Okay, how do you fix that problem?
There was one facility that we looked at that did everything right. And what was going on there was commitment and leadership from the medical director right down to the inspectors, and that's what you need.
So there is someone there is an example at the VA that this can be done correctly.
Yes.
Okay, what would you guess? What percentage of the VA facilities around the country are doing this well?
10, 15%.
10 or 15%. So, Mr. Chairman, there are 85% of the VA facilities around the country who are dispensing drugs illegally or at least in a hurtful way, correct?
I wouldn't say dispensing drugs illegally. They're not following the tenets of the inspection.
Okay, and as a result, these drugs get in the wrong hands.
Correct.
Correct. Okay, good. Dr. Burge, you're in the private sector over at Mayo, correct?
Correct.
Okay, at least you're outside the government sector.
Correct.
Good. Have you found that with an effective drug control program that you can save money?
I believe we can. I believe if you were to ask the executives of the Exeter, New Hampshire hospital that's being, sued, multiple lawsuits, that they wish they had a more effective system.
Besides avoiding litigation, is there a way to save money when you have an effective program like this?
That's extremely hard to quantify, I think. I mean, to have an effective system in place is not an inexpensive endeavor in itself, but it allows you to, we have heard that the word on the street is don't go to work for Mayo because if you're going to steal drugs, they'll catch you.
Gotcha.
So.
Thank you. Thank you very much for being here, Mr. Chairman. Thank you very much.
Thank you. Dr. Dunn, you're recognized for 5 minutes.
Thank you, gentlemen. Mr. Chairman. Dr. Clancy, I serve on a constituency that actually has a Veterans Hospital, the Lake City facility, and there's testimony here that we did not read aloud, but I think you're familiar with, that they had a problem in the Lake City facility recently with a nurse misappropriating the drugs. Can you discuss the corrective actions and protocols that have been established at that Lake City facility in the wake of this incident to restore the quality of care and the level of workplace safety for the community, and also tell me if your current controlled substance coordinator in that facility is properly certified and educated on the management of controlled substances and the supply chain and the management policies.
I would be happy to take that for the record. Our first focus was on protecting patients and then holding the individual accountable, but I will get the rest of the information.
Okay, so you're not familiar with that particular incident in the Lake City facility?
I am familiar with the incident. I'm not familiar with all the details of the follow-up, but we will find that for you.
All right. Let me depart for a second. Dr. Burge, you're an expert in substance abuse, I think, and how it comes to pass. I'm a surgeon. And I've managed operating rooms. I've directed hospitals and large clinics, and this is a problem we all have to address. It's just part of the job that we have to do when we do healthcare, and I've seen this studied at the state level as well. I'm looking at this particular pie chart here that suggests that 90% of the problem with diversion with controlled substances is occurring not in the healthcare facilities, but in the United States Postal Service and in UPS. Now, I'm going to tell you that I've looked at a lot of drug diversion, a lot of problems with this in my 35-year career as a surgeon. I have never seen anything like this reported. This is perilously close to the old excuse, the dog ate my homework. Do you believe that 90% of the problem with drug diversion in this country occurs in the United States Postal Service?
I'm not really qualified to comment on that because that's not where we see it. I'm basically assigned to within the walls of our healthcare facilities. So what happens without, I don't know. That's not what we see at Mayo. We see other forms of diversion.
Perhaps I should redirect that question to Dr. Clancy and say, do you mean by this that the 90% of the problem occurs in the Veterans Administration facility mail rooms? Or do you actually saying that employees of the United States Postal Service and United Parcel Service or people who victimize them are getting 90% of the diverted drugs?
Sorry. What I am saying, and I'll ask my colleague to elaborate, is that between the time the prescriptions are put in an envelope, and understand that we have a central mail order pharmacy, which for most prescriptions works extraordinarily well. It does a high order business, very large volumes. Somewhere between there and the veteran's home where it was supposed to go is where it is diverted. On occasion, we've heard from veterans that that's actually diverted by a family member and so forth. But it could be any one of those points, and that's where working with the Inspector General, VA Police, and outside law enforcement has been very helpful.
Okay, so let's drill down on this a little bit farther, because this looked like we were lagging off on the Postal Service. What's happening is the VA is getting receipt of the drugs from who they purchase it from, and then they're distributing it in their system. Now, they may be using UPS or USPS, and somewhere between once the VA has the drug and the VA passes it off to another part of the VA, the drugs are being diverted. Is that the system?
No, this is outside the VHA system.
So I have to tell you, I've 35 years, I've never heard this kind of accusation, 90% of the problems in the postal system. I'm flabbergasted, Mr. Chairman, let the records reflect my incredulity.
Dr. Dunn, we looked at this. One of the first things that we tried to obtain was good data. I'd be very suspicious of those too, because losses are not always synonymous with diversion. So we got to be careful of that. But the reporting system, VA doesn't have a very good reporting system for drug diversion cases. So I would just be very suspicious of any data.
I am too. Thank you.
Thank you. And Dr. Rowe, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I want to go along with a little bit of what Dr. Dunn was doing. Obviously, we know that there's a drug epidemic, and certainly in the state of Tennessee I live in, it is. And is there any data on how many veterans die of drug overdose deaths, both with diazepines and with opioids? Dr. Clancy, do you have any information on that? How many of our veterans died in that?
We do track that very closely, and we'd be happy to get that for you for the record.
The other thing I have is, as I looked at this graph more, I couldn't figure out how you determined 90%. And, I mean, if somebody is home and just said, well, I didn't get my drugs. Look, the one good thing, if there is any good thing about an electronic health record, what used to happen to us when we would close our office at 5 o'clock, people would start calling in and ask about, well, I just had surgery. We had a big practice 2 weeks ago, and Dr. So-and-so didn't leave me enough medicine. I need you to call me a prescription in. The EMR, I'll just pull it up and say, well, you don't seem to be a patient in our practice. People are very clever at being able to get drugs. So how many, I mean, when you say 90%, how in the world could you ever figure that number out? Because, I mean, you say here that the post office doesn't deliver it. How do you know that?
So I can help with that. This is based on a sample of reports from January 2014 through March of 2016. So whenever we have a loss, we have a template that the individual facility fills out. What happened? Who did you report it to? DEA, OIG, VA Police and Security, and so on and so forth. In those reports, we're able to glean information and identify if it was a situation where a VA staff member diverted a drug, or whether it was a patient calling and saying, I didn't get my package. And our packages are sent with tracking information, so we can tell where it is in the delivery stream. And at some point, if the patient says they don't get it, we have one of two situations. Either they did get it, or a family member got it, or it went missing somewhere. So these are, I agree, these may not be diversions, but these are indeed loss reports that are generated by our facility.
Let me interrupt you because my time is short, but it looked to me like that with the drug, if we can know how many died, if there's a real problem, it looks like there may be a better way to deliver these medications to people than send them out in the mail. I mean, if that's where 9 out of 10 of these problems are, and we're losing a lot of people, it looks to me like that's a sloppy system, if that's the case. Anyway, Dr. Clancy, in your written testimony, you said 92% were lost by mail, and you've sort of answered about how you got at that information. You're reviewing the DEA Forms 106 submitted to the committee. We learned of instances where VA mail controls substances to the wrong address, and worse, to the wrong veteran. How many cases from the 92% went missing, that were missing in the mail, were those delivered to the wrong address or to the wrong person? That's really sloppy.
We'd have to
We would be happy to get that for the record.
Well, just, and we appreciate that, and please take that for the record. Note that the numbers, and bring those numbers to the committee. And for now, what's the VA doing to ensure that they get the right prescription? That's just sloppy work when you mail it to the wrong address or to the wrong person, for goodness sakes.
There is a big part of the effort initiated by Secretary McDonald, the MyVA transformation, that includes making sure that veterans' data is integrated from multiple sources, because after all, many veterans get multiple services from us, so that when they move, change phone numbers or whatever, we've got accurate information. Everything that is mailed out is barcoded so that it can be tracked. So if a veteran calls up a facility and says, my medications didn't come, they can actually track it. There's the tracking number, whether it's Post Office Service or UPS, and ultimately that's helpful to law enforcement in figuring out what happened.
But is that a system we want to continue if the VA, because the VA is a huge system, treating millions of people, and not thousands, but millions?
So you're right, absolutely right, that this is an area where it's not working as well as it should. If we required every veteran to come in to pick up their controlled substances, we could certainly do that. I think it could create some unintended consequences. Some of our veterans live very far away, so we may have to look at some other options for them to get their controlled substances.
I agree with that. It would do that. I'm not saying that you should do that. I'm just saying that we have a situation now where the 30-something thousand people, these are all deaths that are preventable. That's really disturbing to me that when you have probably as many people die of drug overdose deaths as car wrecks now. So it is a huge problem for the entire country. Mr. Chairman, I yield back.
Mr. Poliquin is recognized for one follow-on question.
Thank you very much, Mr. Chairman. Appreciate it. I'd like to follow up what Chairman Rowe was just talking about. It's clear to me, and I think to everybody in this room, that the VA, and God bless them, they're doing a horrible job when it comes to this issue. Why in the heck do we have to dispense the pills from the VA? How many pharmacies do we have in this country? I don't know, doctor. I mean, we got a bunch of them, right? Why in the heck can't we have pharmacies around the country closer to where our population is, where our veterans are? Why don't they dispense the pills if you guys are doing such a horrible job? Dr. Clancy?
I'm sure, as my colleague noted, first of all, mail order works extraordinarily well for other types of medications, and as we work through how to reduce this area of vulnerability, there may be a lot of other options that we could consider.
Good. So in other words, what you're saying, if you're getting an aspirin or something like that, it probably makes sense, but a controlled substance, maybe it's better if it's closer to home, right? Where folks come in and they're known by the folks at the pharmacy, and, you know, we got a problem here, and so forth and so on. Why not? I think we ought to consider that. Now, I don't know what the protocol is, Mr. Chairman, but I bet these nice folks can come back to us at some time and report back to us. I'd like to follow up, if I can, along the same vein, is that Mr. Dahl and Mr. Williamson, my eyes are bad. It's Mr. Williamson, right? Great. You two fellas said that roughly 10 or 15% of the medical facilities in the VA are doing this right. That means there are 80 or 85% or 90%.
That's what I would, you know, we only looked at 4, and the IG looked at 58. But that's based on you know, some
There are a bunch of
speculation.
them that are doing it wrong.
What's that?
There are a bunch of them that are doing it wrong.
Correct.
Okay, good. I have an idea, Mr. Chairman. Why don't we get you nice folks to talk to our great staff here and find out who's doing it right, and we'll have our staff, Mr. Chairman, call up the folks that are doing it right, and let's find out why they're doing it right, and then maybe we can have this nice person, Mr. Allais, or I believe Dr. Clancy you report to, who would be the Undersecretary for Health for Organizational Excellence, have him come before the committee, and then we can see, okay, we've had these folks that are doing it right. Now we're having a problem at the VA doing it wrong. Maybe you can tell us why 80% are doing it wrong. Just an idea. What do you think about that, Mr. Dahl? Think that would work?
I missed that last part, sir.
You think that would work? Would that give us a little bit of help here with the folks that are doing it wrong?
Best practices, it wouldn't hurt to share them.
There you go. We're all trying to get this right because we have a lot of veterans who are in pain, and we got a lot of folks that are having problems with opioids and heroin, including the 2nd District of Maine, that I'm very concerned about. So anything that we can do to help you folks, we'll do that. And I know our great staffer, Kate, will be in touch with you folks to get the names that we talked about. Yes, Doctor.
Just wanted to make the point that we often do sharing of best practices and have a big initiative on that now, and I think it's a splendid idea.
Have you been doing that for the last 8 years?
Not in this particular area.
How long have you been doing it in this area?
We have focused a lot on reducing opioid use.
The last two, the last three?
Couple of years.
Last
yes.
couple of years, but you
Yes.
still have about 80% aren't doing it right.
I am not quite as confident. I think that may be a slightly pessimistic projection.
Even more reason.
But I will tell you when we look, I will let you know.
Thank you. Even more, Mr. Chairman, more reason for us to get the folks who are doing it right to come and report to us, and maybe have the person who's in charge of everybody tell us why the other folks aren't doing it right.
And if I might, Dr. Allais is a woman.
Wonderful. Thank you very much. Appreciate it. Thank you, Mr. Chairman. You're back my time.
Thank you. Thanks to everyone. Thanks to the witnesses. This has been a great next first step as we move forward with a very serious issue here. You are now excused. It is clear from the testimony that has been provided today, as well as the numerous cases we hear about in the news, that drug diversion is a major problem at VA facilities. The lack of oversight over VA's controlled substances and the apparent lack of accountability for failing to monitor proper distribution, storage, and destruction is troubling. We hope that by bringing this issue to light, it will encourage the VA to take steps necessary to impose better oversight and control. I look forward to hearing back on the progress and changes the VA is making. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. I would like to once again thank all our witnesses and the audience members for joining in today's conversation. With that, this hearing is adjourned.